Hello, everybody. Good evening. 안녕하세요. First of all, I would like to say thank you to the organizing committee who invite me for this wonderful meeting and will give me opportunity to present a topic about miniaturized PCNL, when and how. As we know that miniaturized PCNL is one of innovation in PCNL techniques, and since long time ago, 1997, Dr. Chakman and Dr. Hilal first developed mini PCNL for children using 11 to 15 franc vascular access sheet for working access to the kidney. And why we should develop this technique is regarding to the goal of the PCNL itself. As we know that PCNL goal is to achieve maximum stone clearance with minimum complication, and the complication itself are mostly correlated with the tract size, as such as a bleeding, organ injury, leakage, and pain. And the data from the CROW study also show us the benefit of the smaller sheet that decrease the frequency of the blood transfusion. There are some terminology using in this mini PCNL. Mini PCNL itself defines as the access sheet less than or the same with the 22 franc, and the minimally invasive PCNL is 9.5 until 26 franc, and Chinese mini PCNL is 14 until 20 franc, ultra mini PCNL is 11 until 13 franc, and the micro PCNL is 4.8 franc, and the mini micro PCNL is 8 franc, and the super mini PCNL is 10 until 14 franc. Schilling also categorized the mini PCNL into XL until XXS category. Here is the picture of the ultra mini PCNL that using endoscope of 6 franc nephroscope, and access sheet is 11 until 13 franc a metal sheet, which is available for moderate sized kidney stone with a stone-free rate of more than 88%. And this is the micro PCNL that using access needle 4.85 franc all-seeing needle, but this technique is not available of doing any fragment retrieval because of the small caliber. And that's why coming the new modification using access sheet size 8 franc metallic sheet, which allow a 1.6 millimeter ultrasonic lithotripter along with the three-way connector of standard micro PCNL. And here is the new super mini PCNL or SMB that using a 7F nephroscope with enhanced irrigation and a modified 10 until 14 franc access sheet with a suction evacuation function. And this system was tested in a patient with a renal stones of less than 25 millimeter with a stone-free rate was 90.1%. And what are the indications of the miniaturized PCNL? The first is the medium-sized stones, 10 until 20 millimeter, as an alternative for flexible URS or SWL. And the second is small, medium, hard stone with a Hounsfield unit more than 1,000, and patients with challenging anatomy of the collecting system, pediatric patients, upper pole access, complementary tract to the standard PCNL, and patient with anticoagulant treatment. And here is how I do a miniaturized PCNL for the lower pole stone in 1,200 Hounsfield unit. I position with the breast flank-free modified supine position, and then I use a fluoroscopic guided puncture and also dilatation. Here I insert the guide wire. I use always a super stiff wire, and then I dilate with the fascial and then a single metal dilatation until 15 franc of the sheet is inserted. And here we see the stone, and I perform a lithotripsy using a holmium laser in a sitting position. This is the advantage of doing a PCNL in supine position. And the fragment you can see here is automatically comes out with the vacuum cleaner effect. And the exit strategy is partial tubeless with the double G stent. And this is how I do it in a pediatric patient. This is an example of the male, 2 years old, 15 kilogram with a left staghorn stone, 25 millimeters, and with quite the same position as before. And I insert the guide wire and the ureteral catheter using a semi-rigid ureteroscope and do the puncture in the lower pole under the fluoroscopic guide. And I insert the double guide wire and dilate with the telescopic Alkan methods, which is for me is very safe. And then I insert the 15 franc sheet, and this is important for me in the very delicate procedure to do a safety wire outside the sheet. And I do the lithotripsy again with the holmium laser, and again the vacuum cleaner effect helps me to retrieve the fragment of the stone. And then I inspect the track of possible any injury or bleeding. If there is no any significant pathology, I will leave the double J stent and no nephrostomy was needed. And this is my another cases of left staghorn stone. And this you can see the stone fulfill the lower pole and upper pole. So I plan to do a double puncture. So I puncture first the lower pole and put the superstiff wire. And then I perform a second puncture to upper pole and leave the cat wire also inside before I dilate the first puncture. So, and then I proceed with the dilatation of the lower pole. And you can see here I use firstly a mini perk to assess the hardness of the stone. And if it's really hard, and I can convert and by further dilatation of the same track to the standard PCNL, and I can easily remove the bulky stones in the lower pole and in the pilum. And then I continue with the second dilatation. I use the mini perk for this part to avoid bleeding, since the upper pole dilatation bring more risk of having a bleeding. And you can see here when I perform a nephroscope with the mini, the standard PCNL will make a pressure normal. And this is what I did. I put the nephrostomy on the lower track. And this is the result. So how is the mini PCNL versus standard PCNL? If you see the paper from Dr. Misra here, the mini perk is associated with a similar clearance rate as the standard PCNL for stone size 10 until 20 millimeter, with a lower hemoglobin drop and higher tubeless procedure here, and also lower analgesic requirement, lower hospital stay, but of course with a longer operative time. So longer operative time is price that you have to pay for the miniaturized PCNL. And here is also the newer paper comparing a mini PCNL versus standard PCNL. And this paper states that mini PCNL is superior to standard PCNL with less blood loss in a small and medium-sized stone in 10 until 30 millimeter size, with a safer and stone-free rate as high as 96%, with a shorter hospital stay and higher rate of tubeless PCNL rate. And here is also the paper comparing the mini PCNL versus RIS by Dr. Sapnis. Here, that the both technique is equally safe for the stone 1 until 2 centimeter, but the clearance rate is equal and the operating time is significantly faster in the mini perk, and the double G stand is lower in the mini perk, but pain is higher in mini perk, but compromised by the relief of DG stand symptom in mini perks. And here's also the systematic review and meta-analysis comparing mini PCNL versus RIRS. And here the result is meta-analysis show that the mini PCNL group led to higher stone-free rate, but with also larger post-operative decrease in hemoglobin level compared to RIRS. And this is a review from Dr. Sylvia concluded that miniaturized PCNL represent a valuable new tool offering a good outcomes with a lower complication rate compared to the standard technique, but with a higher cost effectiveness compared to flexible URS. The question is, how small can we go? Of course, with the further going down with the miniaturization less than 15 franc, we are facing some problems. Like the first is prolonged operative time. The second is compromised vision with the poor irrigation flow, especially when we insert our instrument with only laser available as energy source, difficulties in fragment retrieval, high intrarenal pressure lead to higher infection rate, and fragile instrument lead to higher cost. This is the comparison between the miniaturized PCNL using a survey method in the European Association of Urology section of urolithiasis. You can see the conclusion is mini PCNL in size 14 until 20 franc is the most effective and safe procedure among PCNL techniques for the stone size 1 until 2 cm. And the other technique like micro PCNL appears to be the most time-consuming technique and probably require highly selective indication. So my conclusion is the miniaturized PCNL is a safe and effective alternative for the treatment of the renal stones, and mini-perk with the size 15 until 20 is a standardized option with no remarkable benefit in going smaller, and more randomized trials are needed to confirm the advantages of the smaller MIPS, MIPXS, and micro-perk. The main concerns are operative time, intraoperative pressure, fragment retrieval, and fragility. I think this is the end of my presentations. I would like to say thank you to all my mentors here, and I hope all of you stay safe during this pandemic, and I hope we can see in Bali in UAA Congress 2023. Thank you. Hamsamda.